Welcome to Pause Vibe Podcast, a podcast for HIV positive people, their friends, family and allies. Listen wherever you get your podcasts.
Welcome back everyone to the Chem Sessions.
Chem Session number 14 and our first Pause Vibe podcast of 2026.
I know we have been away since the start of the year, but Chemsex has not gone away.
Yeah, that's true. And we're back there, folks. And, it's a heavy topic. It's controversial. It can be weighty, but we really need to have conversations about it because it's become a real situation in our community.
I keep thinking back to when I was at the Gay Health Forum last year and I was asked to kind of give a reflection on the National Sexual Health Strategy. And so when I was reading this 80-page document of what this sexual health strategy is for the next 5 years, I found myself shaking a little bit with anger, I suppose, because there was only like one bullet point on chemsex and there was nothing really definitive about what they were going to do about chemsex. And the reason why I felt shaky was not only because we'd done the chem sessions previously and we heard how chemsex can really affect people negatively, but I went on a hike with my friend Anthony a few days beforehand and we counted off the people who we knew died of a G overdose. And we counted to four people who died of a G overdose.
Wow.
And yet we have this bullet point in a national sexual health strategy that really committed, in my opinion, to nothing of substance. I was so let down by it that when I was given this 5-minute reflection, that's all I could talk about. And I talked about one of the loveliest people who I've ever met. And he was a very young lad and he was found one day dead in his bedroom, dead of a G overdose. And I really wanted to use his story to highlight how big of an issue this is, or crisis for people, and how much attention we need to bring to it. So I'm so happy we brought this Chem Sessions back to talk about it. It is heavy. People can use chemsex to explore kinks, to have fun, to enhance sex, and we know that can be used if it's used correctly and responsibly, but we also do know there's another side to it. And I think what we'll try to do today is what we've been trying to do all the time, is to try to balance the messages and with those stories. And we have that with two fabulous guests today.
Yeah, two wonderful guests. One who we've had on the podcast before, Graham Ryall from St. Andrew's Community Centre, and our newest member, Ralph.
Hi Ralph, how are you getting on?
So happy to be here. Thanks so much for inviting me.
Ralph, you're a public health consultant and all-around fab guy, right?
So not yet a consultant.
In my mind you are.
So public health doctor working for the HSE, and I'm leading out on the CHEMSI survey, so the first national survey on chemsex in Ireland. So really, really happy to be here.
We'll be getting right back to that survey. And Pause Vibe just promoted you to consultancy, so I hope the HSE pays you accordingly.
Thank you.
Graham, can we bring you in straight away? You, just through Pause Vibe in general, I think was one of the most powerful and impactful interviews we've ever done that has stayed with me. Anyone who I talk about you loves and adores you, and they love how straight talking you are about this topic. So thank you for all the advocacy you have done behind the scenes and in front of the scenes for so long in this. Do you want to kind of discuss in your kind of service the new trends that you see emerging around chemsex?
Thanks, boys. I'm absolutely honoured to be invited back in here with every one of you. Because one of the first things that was ever mentioned to me when I really started working in this whole area in 2015 was, we have to get this conversation going. And it's brilliant that Ralph and this study is happening because it's taken 11 years. You've hit upon so much in your introduction, the two of you, and I've just put a note here. You've highlighted the two major emerging themes from 2025 for me, and that is number one, the number of individuals now consuming chems in isolation, and there are many deep, sometimes dark reasons for that. And again, further complexities to this already incredibly complex phenomenon. And that's what this chemsex thing is. You wouldn't think it in Ireland or in Dublin. Those who are in it see it, but outside of that, and hopefully, the CHEMSI study will actually highlight that. But the other one then is, really sadly, not a week has gone by, and I'm not sensationalizing here. Not a week has gone by since October that someone has not mentioned to me someone close to them who has died. And the the silence, as we've just had, right, to me speaks so loudly about that these things are not being discussed.
Yeah,
and I remember
because-
on the Chem session I did, which is number 10, that was one of the things I highlighted. Like, there's no conversations about these things. And then, you know, when you're supporting someone who has lost someone very, very close to them, survivor's guilt, further isolation, loss, and isolation, loneliness, and loss are the biggest themes I work with people. And when I'm doing talks, I put up a slide of the many underlying determinants of what is driving the kind of more darker chemsex participation and chem use. And they are isolation, loneliness, and loss. And that silence adds to that. And
it reminds me of people dying of AIDS in the 80s and 90s, that people don't want to bring it out as if it's a terrible, shameful secret.
Mm-hmm.
So I know even in my world, the people who I know who've passed, who've been part of a chemsex community, it's not something that we ever tie to them when we talk about them.
yeah, like I'm reminded of that excellent documentary on Vincent Hanley. And like, I'm old enough to remember MTUSA, you know, back in the mid-80s, and the coinciding of the AIDS epidemic and how his family silenced the actual reasons why he was sent to America. And, you know, and this isn't for 1 second damning families or anything, but, you know, there's no mention of chems, you know, so we're not getting any numbers about this. And I was talking with Ralph about it, like, that these figures are not being highlighted. And yet, in the summer's coming up, right? And music festivals, and I've worked at the Mother Festival and stuff. You know, within 2 hours of the Mother Festival starting on that Friday afternoon, on the big screen behind the main stage was high strength MDMA, please be careful, right? But yet, there are people, you know, there are fatalities happening, and I am not sensationalising anything, being tabloid about it, creating a moral panic. I only talk from the experience of working with people. And this is what's happening. And it's, again, further isolating people. And on the last time I did the number 10 Chemsex podcast, numbers of people contacted me and from the country. I can't believe what you were talking about. I thought I was the only person. You know? So it's you're absolutely spot on. It's re-triggering so many traumas for individuals, but also for the community as a whole.
I've a question, because I don't think we should brush past this, because if we are hearing about so much death, right? If me as one person can think of 4 people, you know, Veda has people in their lives, you see your clients talk about it all the time. Surely there's a number with that would shock all of Ireland, that there's this phenomena that's happening and people are dying from it, right? And yet there's very little harm reduction happening. There's little to no outreach happening. Where's the resources? Where's the well-being? All of this. But the reason we're not collecting the data on deaths related to G overdoses or whatever is because we're not collecting that data. Do you want to give kind of let our listeners understand why that is?
It's one question I genuinely cannot answer, because I've been advocating, at times agitating to highlight this.
I have a theory, a little bit of a theory. It's like, I think it has got to do with the isolation that you're talking about too, is that oftentimes people come into this community, feel this great connection and togetherness through these chemsex parties, but go through this process that ultimately leaves them drug addicted, isolated and alone. And I think oftentimes their death is not at a chemsex party, it's not attributed to this scene, but the negative outcome started at that party.
But if a young person dies, or just anyone dies unexpectedly or on their own, a post-mortem does happen, right? But as part of that, as the toxicology report doesn't look for G. So if we're not collecting that G is the thing that killed someone, we're not collecting that G-related deaths. Therefore, we can go to the Department of Health saying, give us money, people are dying, you know. And so it's really a structural issue and then a very individual issue as well. Graham, I have a question about isolation, right? So you're seeing more and more isolation within chems.
Yes.
And Veda, just connecting to what you were saying, anytime we hear about chems in the community, it's because people feel that connectedness, the intimacy, that feeling of, being part of something and having their mates. And especially if you're coming from Kerry to Dublin and you're just coming out as gay and you're like, woo, some of all these gorgeous people, and drugs are making sex way better because, you grew up without any intimacy because you were afraid of being called queer, faggot, or being bed up. How did we go from this forced feeling of connectedness, of great sex, to maybe smoking meth by yourself in your house?
Tina, because no one's ever mentioned meth to me. It's always Tina.
Tina, yes, let's be. We were always good about
and language is so important because if an individual engages with a service and they're going, okay, well, what do you mean? Are you injecting crystal methamphetamine? That person's going to go, right, this person doesn't know what I'm talking about, and they're not going to come back. So language is so
slamming
important. Slamming Tina, right? But yeah, I think that, when someone, and listen, the vast majority of people who engage on the chemsex scene, it is a very enjoyable, pleasurable, disinhibiting, and formative experience for people, right? I'm very positive, right? But there are those, and again, this touches upon that, again, those deeper underlying issues that are then tapped into and triggered the more someone gets into the scene and gets into the chems themselves, G and T, GHB and Tina. And, a cocaine hit is 350 on dopamine. A Tina hit is 1200.
Wow.
Okay? What goes up comes down. And when Tina comes down, it comes down very, very quickly. And when someone has been, say, partying for 2 or 3 or 4 days or whatever, probably very little sleep, and suddenly, what's this feeling? Why am I thinking what I did when I was 8 years of age or 19 or whatever? And you go, I don't like this. And that's where people then very more than likely continue to, what I call self-medicate. Right?
And it's addictive, right? It's as simple as
that. It's a psychologically addictive substance.
Yeah.
GHB, a very physically addictive substance. So there's a huge difference between the two there on that one, right? But the vast majority of individuals engaging, Tina is much more prevalent on the scene than GHB.
Really?
Yes.
It was the other way around prior.
For the first 2 years or so, for me anyway, right, 2015 to mid-2017, certainly the vast majority of first-time engagers, it was GHB. But from the summer of 2017 onwards, and for last year, right, at 51 new people who engaged last year. And just a breakdown of that is that of that 51, give me 1 second, T-related was 43.
Wow.
G-related 31. All right. Now in that, that would say be T and cocaine, T and methadone, T, G and ketamine.
Polydrug use.
But yeah, absolutely. Very few people just take one substance.
Are we talking about slamming or smoking more prevalent?
Certainly, slamming is increasing, right? And there are again complex issues for that. There's the fetish about it. There's the intimacy of slamming. People are being coerced into it, right? It's seen as something further illicit. So there are many, and it could be just down to I'm not getting what I used to get from smoking Tina. So I'm going to start slamming, right? So again, like I said earlier on, all parts of this, there are so many complexities to it. But I think that it's people's response to the come down and that deep, dark place that they are brought to, that, was on very, very small fine print the first time they ever experimented or recreationally or used any of the chems, right? Everyone knows the positives. And for such an educated, cohort of individuals, very few of them know the downside of the chems and the scene. And that can then lead to people being very vulnerable and open to exploitation. And that's one of the really dark areas that has really come to the fore. And it's not just because it was COVID, but over the last number of years, is the exploitation that is going on out there in relation to people.
Can you give us, exploitation seems a bit abstract in a sense, right? When you say, because it could mean many things, it's quite broad. Could you give maybe an anecdote or something, or like, it doesn't have to be a specific case? Or like how
have you seen Death Becomes Her?
Yeah.
You know, when they say, now a warning, after she's already taken the potion. That's what I'm getting from it.
All right. No, listen, the first one that comes to mind, and again, these would be some of the extremities, but again, these are the issues that I'm working
people's
with.
realities.
People. Yeah. Is where someone might be put under.
Okay.
And when they come through, they are being raped. And that's one thing in itself. But what can also come from that is that is being filmed. And that person could then be blackmailed. And the effect of that for an individual, because, you know, not everyone who is on the scene is a gay man. I'm working with quite a few heterosexual individuals who would classify themselves as being heterosexual, but again have been drawn to the scene, and you know, the openness, the inhibitions being literally blown apart when you take the chems, and they're not aware of the consequences or complications of what they may be involved in. But again, I am working with a number of people. Can that individual, and I've done a number of talks across the country alongside a very good colleague, Derek Byrne from M.Sc, and some of the teams that we would be talking to there, and some of the groups, as in on Garda Síochána, that given them those scenarios and go, well, can that individual who's been raped at a party in a hotel or someone's house or whatever, and who has been blackmailed, can they come to the police and report that? And chances are they can't. They can, of course, present, but are they going to do that? And the answer to that, sadly, in most cases, is no. Because if they press charges or whatever and there's an investigation, well, then if it goes to court, they're in the paper. And if you're a professional or working class area or whatever, right, and that is in the paper of where you've been and what happened, you know, so the perpetrators of this violence, and that's what it is, they know they're more or less safe, that no one is going to go further with this.
And let's be honest, I think the queer community, we have an interesting relationship with the police, to be honest, right?
Yes.
Not to tarnish the police, I can't generalise. There's some really great allies. You know, I think G-Force is out there doing great work, if that's the name.
It's great.
Yeah, it's a great name, right, G-Force. But at the same time, we also hear horror stories, and the history of the police and LGBT community that, let alone dealing with all the internal shame of coming with sex, going to a sex party or being raped at a sex party, you know, and doing drugs and all that fear wrapped up in it. It's a concoction to make us not want to report this, but then the perpetrator could be fucking serial rapist. It's just mind-boggling to think that this is happening.
And there is grooming going on, and power play, and people are being coerced into the scene by what has happened, right, and being again exploited. And certainly the exploitation of escorts and trans escorts is horrendous. And I want to also bring up the issue of intimate partner violence.
Please do.
You know, a really good study into intimate partner violence within same-sex couples in America refers to IPV or IPA as the double closet. It is not talked about. And I've looked into this quite a bit. There are higher rates of intimate partner violence, domestic violence within same-sex couples as there is in heterosexual couples. And yet it's only in the recent campaign, which is a really good campaign, that same-sex couples were actually used within that campaign, which was great, because I've had to sit with people and go, what do you call what is happening to you? And there's an added power play of, say, if someone is HIV, or even if they have not come out, you know, that coercive control, psychological abuse of, well, if you leave me or whatever, I'm going to tell people you're HIV positive. I'm going to go to your work and tell them that you're a gay man. So there's so much more power play. And again, I work with people who have unfortunately presented to the Garda, and I've not got a good response back. Like in one case, which again was, you're a man, aren't you?
You're a what? Sorry?
You're a man. Man up. That
Look at the world that we're living in. Look at the news right now. The amount of triggers that we're all consuming through social media about Epstein, Trump, Prince Andrew, and no prosecutions, no one being arrested, nobody being called out on the carpet. So when you filter all of that down into the culture of a sex party, it's really understandable how people feel powerless to do anything about the rapes that they're experiencing.
It's a really good point. And again, I am being completely honest. A couple of weeks ago, one of the guys, he relapsed. And, so listen, what happened? And he says, I don't know, Graham, talking through it. And I just said to him, you reading the newspapers at the moment or watching your news or whatever? And he says, oh yeah. I says, is that affecting you at any level? And it was the Epstein thing.
Yeah, I'm a
and we
survivor
talked
of
through
abuse, and I find it very
hugely
hard every
triggering.
day.
I think anyone who's experienced child sex abuse, and we know it's like epidemic levels around the world, and especially in Ireland, and then see no accountability, the survivors not being listened to. Prince Andrew is getting charged, but for giving government secrets away, not for actually the rape of young women.
Yeah.
It's extremely, extremely hard, extremely difficult. And then that heaviness, we ingrain it whether we think it's conscious or unconscious, and then it can lead to behavioural issues. And also, I think we have to have a lot of sympathy and compassion for people who relapse, because it's part of the recovery journey, isn't it?
It absolutely is.
But I think that's why people like you are so important, and, people to reach out to people in the community, because we're like, what do you think? Set off that relapse. We're not judging you.
Yeah.
This is happening. Let's start from here going forward. I think we really need, because it's a very hard recovery process, right?
And like for someone to engage, like we're a community drug team. The Rialto Community Drug Team is a community drug team established to address the heroin epidemic in the South Inner City in the early 90s. And for someone from the LGBTI community, GBS, MSM community, to come into a project in the South Inner City is incredibly brave. And they will come in, and it's like they have an iron coat of guilt, shame, blame. I never thought I'd wind up here.
Yeah.
Look at me, I'm an addict. And when we start talking, I'm going, are you really an addict? Are you self-medicating? And people come in, they're so anxious, so tense. And I promise you within 5 minutes you are going to be relaxed. And it's about breaking down that guilt, shame, blame, again, those underlying determinants that have been thrust upon the community from day one. And that's what you start to break down, because as Gabor Mate says, addiction isn't the problem, it's the attempt to solve the problem. And to say to someone in that compassionate, empathic way, listen, you're not an addict. It's a horrible label. So yeah,
there's so much healing even in that. I've never heard that before, or I've heard it said differently. But when you say it like that, it kind of hits you a little bit different.
But it is the case.
Yeah,
people just see the person and the substance, right? But not the reasons as to why that person is behaving that way. Like as I said to people, I said this to a guy yesterday. Would we be having this discussion 25 years ago? And the issue, because he's on the scene, and the issue was no. It would be cocaine, it would be ecstasy, alcohol, right?
Yeah.
But it's this new phenomenon since the late 90s, which has, come across the world. So it's just another way of looking at it, right? That why is it that T&G are confined to this community?
Yeah.
And as David Stewart said, it is responding, right? And what he says to answers, I would actually say it's responding to questions within the community. Because if you have an answer, well, then do you really know the question?
Can I ask you, if someone is self-medicating like so many of us do, but let's say functioning, what is the alternative?
That's a really good question. Right, what are you self-medicating against? or for. And like, again, one of the themes over the last number of years, and I touched upon this the last time we spoke, is neurodiversity. There are higher rates of neurodiversity within the LGBTI community than the general population, sorry.
We call general population generic too.
Yeah. You know, and if you're working with someone and, you know, they've been 2 or 3 days on Tina and Graham, I'm sitting down and I'm relaxed. I'm chilled. I don't feel bored. I feel calm. Like, I did a session last night with a guy and he says to me, I'm working 6 days a week. And I said, are you? He's working 5 days in his job all day Saturday. When he goes home at night, he's having a few puffs and he is working until 2 or 3 in the morning. He's literally working 18 hours a day, 6 days a week. Right? But he's actually using, because he contacted me last Sunday and said, look, can I please come in and see you this week? I need to see you. And he was saying, oh, I'm using a lot of Tina. But when we broke it down, he was actually using it to actually work.
He's using work and Tina.
Yeah, that he's able to focus on it, right? So just, I think that the neurodiversity, to go back to your question, the neurodiversity is that it calms people down. That the madness isn't in their head, that they feel calm. And the word, and I hate when they say it, I feel normal.
But people say workaholic a lot. I grew up with that expression because, you know, there might have been a lot of alcoholics in my family, but they were also workaholics. So they have that, I guess, a shield that protects them socially because they drive Mercedes and, you know, live in nice houses. And so workaholic was always something to aspire to be, and we still have some workaholics. I might aspire to that myself at times. But it is, you know...
Listeners at home, Veda is a workaholic, believe me.
But it is a form of self-medicating as well.
Yeah.
And I find that my thing can be a mix. Like I'm not smoking Tina currently. It's not been my experience. But self-medicating and working at the same time, or using work to self-medicate are things I can relate to completely. And I can think of friends of mine who've had amazing educations while I've known that they've been using a lot of Tina, for example, or really excelled at their job for a short while, you know, while I know that they've been using Tina all day, every day.
Yeah, and like for me, if someone say, you know, is say 6 months physically addicted to GHB, taking 2.5 mils every 90 minutes, they are not taking that for any euphoria. They are not taking that for any incredible sexual experience or any incredible social experience. They are literally taking that to stave off withdrawal. And withdrawal from G is absolutely horrendous. In extreme cases, it can be fatal. Right? For someone using Tina to self-medicate, as I would say, it could be in relation to either undiagnosed or unmedicated neurodiverse condition, or in most cases, to stave off that withdrawal, that the darkness coming into their head, that they're having a couple of puffs, that they don't want to go into that come down. But you know, it's only literally kicking the can down the road, because it is going to come back eventually.
Isn't it true that Ritalin is an amphetamine or whatever? It's like meth in a pill, basically, right? Obviously, much more, controlled and manufactured, but it's basically given people with ADHD that clarity of mind, right? So you can see how people feel quote unquote normal.
Like one of the unfortunate kind of consequences of it is that, and again, a lot of the individuals who would engage with me, you know, are in very good jobs and stuff like that. So financially, they can go for that assessment, right? Which is expensive. Those that aren't as affluent, they cannot engage for that assessment for ADHD or whatever other neurodiverse condition they may have. And what's staggering for me is that of those who have gone through the process of assessment, diagnosing and medicating, 2020, mid-24 to 25, I had 11 individuals who went through that process. Only one of those have relapsed.
Wow, that's amazing.
There is no access to neurodiverse assessment through the community sector. You were saying about I'm the one that's highlighting all this, right? Getting into trouble sometimes, but anyway. community mental health are adverse to addressing neurodiversity. I have been told by services, Graham, can you get the GP to refer that person again, but not to mention neurodiversity because it will not be looked at.
Wow.
And yet we are seeing huge rates right across the population, not only the LGBT or GBMSM. And this, to me, this is the next thing. It should be up on the same level as trauma. And for people working in addiction, it's all around trauma-informed care. We should now have neurodiverse-informed care.
When I was a kid, you were either a good kid or a bad kid.
The ball by disease.
That was as far as it went in terms of diversity or neurodiversity. Yeah. I'm sure things are quite different now. Ralph, you would have a different perspective.
Yes.
Being a young man. Get in on the conversation.
So let me bring you in, Ralph. We've been screaming for so long that there's been a dearth of information around chemsex or data around chemsex.
We want to get dirty.
We want to get dirty because we know we need data to advocate, right? We really do. There's no policy without data. So first of all, do you want to give people kind of an overview of the research that you are doing, but also from your research previously, what research is out there about chemsex in Ireland and what can that tell us about our current situation? If it could tell us anything.
No, of course. No, thanks so much, firstly, Robbie and Veda, for having me on to talk. And it's an honour to be with both of you and also to be on with Graham. And actually, I can't just thank Graham enough actually for how much he has helped in informing the survey and just how much he's doing for this issue in Ireland. It's actually quite incredible, and that's already coming through on the survey. I can't really give the results more than that, but already there's a huge amount of support for Graham. So I suppose just to highlight what the survey is, so it's the first national survey on chemsex in Ireland. So it's building on, there was a previous survey done in 2016 by Ronan Glynn and a group of people working in the Gay Men's Health Service. And that was a really important piece of research. It was kind of the first, I suppose, quantitative piece of work, like the first piece of research involving statistics, you could say, on chemsex in Ireland. And that was based on people attending the Gay Men's Health Service. There was over 500 people that filled in that survey, and about a quarter of them reported using a chemsex drug within the previous 4 weeks, I think, previous year, I think it was, of kind of completing the survey, which I think was news to a lot of people. This is actually
1 in
a real
4
issue.
is huge.
1 in 4 is huge. So I suppose it showed, again, this is a really important issue. The thing is, like, since 2016, like, Ireland has changed hugely. There are other pieces of research looking at chemsex in Europe, and they would say that, like, Dublin was a relatively late adapter to the chemsex scene. Like, we're not, like London or Berlin or Paris. But now, we probably are, maybe not quite to the same extent, but we don't really know, I suppose. So it's really important to have more data. Certain, like, stressors, you could say, are the same in Ireland. Like, there's still homophobia. There's arguably, like, certainly a lot more transphobia. Certain things are better, like particularly in the world of HIV. We have things like SH24. There's a lot to celebrate. But there's also maybe other factors, like housing is an issue, and many other factors that affect people and may affect how people use chems.
Racism.
Racism, 100%. 100%. So the idea of the survey, it was from, there's a group of incredible people working in the HSE Sexual Health Department.
Shout out to them all.
Shout out to them all. So led by the amazing Professor Fiona Lyons. And Fiona and her team is Caroline Hurley, Sinead Woods, Rachel Matrusty, Nicola O'Connell, all fabulous people. And together with another icon, Derval Igo from Public Health, they kind of realised we really need to have new data on what is happening within Ireland. So that was back in the summertime, and kind of over a period of months then we were planning, like, okay, well, what questions do we need to ask to get more information about what is happening? And we deliberately didn't want to ask exactly the same questions as before. Like, we weren't interested in, like, how many sexual partners somebody has had, over a given period or things like that. We weren't even necessarily interested in exactly the proportion of people using chems, because we specifically wanted to hear more from those using them. But we wanted to find out, like, firstly, like, what kind of population are using chems? Where are people using them? Is it in Dublin? Is it in rural areas? Like, what ages are the people? Like, are they people that are from a particular, background, etc., so that services can be better designed? And that's really the key thing, is that there is a need, an urgent need for better services. One of the other key aspects is mental health, like people's mental health, be they people within the queer community that are using chems or that aren't using chems. Because certainly one of the, I suppose, the theories might be that, like, there are people that are using chems and having, like, positive experiences and are using them to have, like, great sex and connection. But there are also people that may be using them in a way that may have just more vulnerabilities in general. And I think something that has, when talking to people, and even my own experiences of the healthcare system, both as somebody working in hospitals, for like a long number of years, and as a person myself, as a family member, as a friend, is that there is a massive crisis within mental health care in Ireland more generally. So we wanted to kind of figure out what are people's experiences of what are people's mental health experiences, and what are their experiences of mental health care, both people using chems and people that aren't using chems. And then kind of lastly, we wanted to find out, like, what chems people are using and what are people's experiences of chems services and the effects they're experiencing from chems, be they positive or negative.
Yeah, it's a fantastic survey. I filled it out. Have you filled it out, Veda?
Not yet.
It's well worth doing. You could see, has it been informed by a PPI, public-private investigator? Because you can see that there is a bit of community voice, whether it's you, Graham, or someone. Because one of the questions that I really liked was, it was something, I'm paraphrasing, you'd know this, Ralph, but it was kind of like, if you are a party, would you help someone if you see them go under, or whatever, and it was kind of nice, because I think that's data that we need to collect, and it'll help us inform toolkits then for the community, because this is not about telling people don't do chems, it's about harm reduction ultimately. So it's a really great insight in what's working for people who are engaging in chems, or what's not working.
Can we answer that question? Because since we bring it up, what do you do if you're at a party and someone goes under?
I think that you would need to look at because not every chemsex party is the same.
Yeah.
All right. And again, say those that are, far more stable and managing their participation and use, there would very possibly be someone there that's making sure everyone's okay, or that kind of unwritten contract between those that are at the party. But again, and especially with the individuals I'd be working with, which again, are at that darker end of the scene, right, and more chaotic. Is there someone that's going to mind people in that situation where, it's literally an open door and people are coming in because there's a dealer present, and again, this is the reality of it. Yeah. There are a number of apartments across the city, and I have absolutely no doubt in other cities or towns across the country, because this is not a Dublin-centric phenomenon, that if someone gets into difficulty, they are put out the door. I have had phone calls from hospitals, from Garda stations, they've picked up someone and they've given my name and number, that individual has been put out of an apartment because they've gone under, or and again, like, not everyone who goes under goes into that slow sleep. Some of them go feral, and the last thing anyone wants is someone screaming, shouting, being unpredictable. That person is put out.
Yeah.
Right.
And when you say mind someone, what do you mean
the
by
whole
mind
thing say
someone?
about, say, G, because again, it's, say, the first 2 or 3 hours, right, I've taken G at 6 o'clock, so I'll have my next meal or meal and a half at 7 o'clock, right? But if you've day 2, day 3, day 4, and you've not had no sleep, you've probably had a range of substances, of chems, that, okay, it's 3:30, right, I've had a shot at 2:30, so time for another shot. You could be sitting there, and this is where, because a delusion is such a kind of a common factor with people. Did I have a shot? Did I have a shot in the last hour? Oh, I don't think I did. And they take another shot, and yet they probably had one 5 minutes earlier. And that's where the risks of overdose happen, right? Because again, the unpredictable nature of the cocktail of chems and whatever, and lack of sleep and food and stuff, right? So the risks are highly increased, and again, I go back to, it's one thing about in the party situation, but if someone's doing that by themselves, and and say they're on a Zoom party room or they're watching pornography or whatever. Did I have a shot recently or whatever? That's when risk can happen, you know, and that's why I think some fatalities are happening. But the thing about the safety person is people that, you know, I knew a couple of years ago, oh, I'd be the one that makes sure everyone is okay and that they're getting the right amount of G and there's no one taking advantage of anyone. Unfortunately, some of those people are now in a chaotic situation and they are not minding people and nobody is minding them. And, you know, a thing again commonly discussed is that paranoia and delusion. Everyone in the room is talking about me. Everyone's, you know, what are they putting in that G, you know? And that can spiral someone's mind to a really dangerous place. So, you know, when someone starts behaving, no one wants that.
Yeah.
And they're not politely asked to leave, you know?
Oh my God, I could ask a million questions based upon that. But first, Veda, I want to hear from you, because I would call you the hostess with the mostest just in general, not a Chemsex party. But what do you think works when you're hosting, you feel like people are a little bit off? I know it's a different situation when there's drugs involved, but, you know, can you give any tips to our listeners about what you think might work?
Well, in general, as a hostess, when things are going left with an individual, if there's a window there for me to find out what their story is normally how I try to go. Like if they're in an argument or upset about something, or, you know, what's, like, as Graham said earlier, what's driving that, what's behind that. So I think in general, that's a good way to deal with conflict. But as a hostess, there's so many things that come to mind. I read this amazing post earlier today by ACON, which is a HIV/AIDS organization that Robbie and I worked with in Sydney in Australia. And it was a great post about party planning, essentially. It was about how to be a good host, as we used to say all the time. But it was about planning the details of the party to build in some safety measures that might not usually be there in a more chaotic situation, which are things like clear notes on how to get in and out of the venue, or things like, which one that never occurred to me before is, where are the pets? What's happening to the pets?
Who's looking after the doggies in this 3-day bender?
Who's looking after the doggies? You know what I mean? Like just stuff around that, you know, around having, for example, a number of hosts, because people's moods change or situations change, or the host goes under. So this idea of a tag team of 2 or 3 hosts where, you know, you are now the host, I'm no longer the host, I'm now just going to throw myself into the party, but having a clear plan around things like that. Please, Graham, you want to get in there?
I've often got phone calls late into the night or early into the morning, right, of people just looking, Graham, listen, something's kicking off here. You know, it could be someone going under and in that kind of feral state or whatever. And it's about getting an ambulance, you know, and it's always better to err on the side of safety. Like, right, we can't do that, Graham. We can't get an ambulance. There's no way we can get an ambulance. And when they're not the police, they are not going to confiscate or arrest you around. They're here for the safety of that individual. That is what is paramount. If someone hosts a party in their apartment or a hotel room in their name and something happens, a fatality, they're done for manslaughter.
Wow, I did not know that.
Yeah, because if it's their apartment or house, they were hosting. And if something, and again, these are the extremes, but the extremities are happening. We have to discuss them, right?
Can I ask on that, just as a practical, if I was hosting and someone went under and I was afraid of calling the ambulance, because do you know when you see ambulance, police and fire brigade all coming at once sometimes? Could you just say just the ambulance? Is someone under for drugs? Or like, it doesn't have to have the police involved?
Yeah,
just
but sure, that's what it is.
Yeah. And
just to listen, be honest, tell the ambulance guys what they've taken. They need to know that information, right? One of the, again, I'm reminded of one particular person that engages with me, and this evening they will get a text about 5:30 of where a venue is happening. And there's a 10 or 20 euro. This is something completely new now. There's a 10 or 20 euro charge sent on Revolut, and you are given the address of the venue. And yeah, so that's happening in Dublin at the moment as well. That it's not just someone's house or apartment or a hotel room, that it is now a warehouse.
Wow. And
Yeah.
people are making money that way.
Yes.
You know, obviously people selling drugs are also making money, but now
A
people,
lot.
hosts making money
Yes.
as well.
Listen, this is capitalism in its purest
I was going to
form.
say, I was like, capitalism will be capitalism.
Yeah.
Thing.
And listen, sorry, just on the safety thing, because it's really important, because again, this comes back to an experience I had, that one particular, Graham, it's grand, we don't need to get the ambulance, he's asleep, he's in the room now asleep, he's calmed down. And I went, right, will you just go in and check on him? And he came back, and he says, Graham, he's fine, he's snoring. And I went, now you have to get the fucking ambulance. Because if a person goes into that deep sleep, but they're snoring, that's their body starting to close down. Ambulance has got to be called, because that person is in danger then of.
See, it's so easy if you're high or someone else is high to be in denial about these things, isn't it? So having these clear indicators of when to call the ambulance is so important. And I think this is where outreach is so important. People need to know this. I don't think this is readily known.
These conversations.
Well, we're a culture of binge drinkers as well, and drinkers in general. So this idea of, he's grand, he's asleep now, and that's what we think of as being the safest place.
And right across the board in relation to drugs and chems, Irish people and British people are very different to Europeans in my experience, that we want to guzzle them as quickly as possible. And guys would say to me, Graham, I want to get as fucked up as quickly as possible.
Mm-hmm. Especially if you have insecurities as well, right? And all of this.
This is where the sociality, because it's not just about chems or about sex.
Yeah.
A huge part of the parties, and this is where the isolation thing then is really important, right, for people that are doing it by themselves. But the sociality of that environment is so important. It is so important. And the amount of talking that goes on, because people can relate to who they're with. Right, and that is such an important part, because that's what attracts people to the scene, is that I'm with my own people here, right? And so that's a huge factor, and I think absolute credit to the Kinder group.
Yes,
that it's not only peer support meeting 2 or 3 times a week, but the social element of it, and to have, I think they've done that walk in Spain. Camino recently, and they'd often go to various places down the country, whatever. But that whole social aspect of it is so important.
Can we just say for anyone listening, Kinder is a group that meets in Outhouse, and it's a peer support group for people who are using
and
drugs.
that it's through the 12-step model, right?
Okay,
and that's important to say, right? And I think I'll highlight as well that Solcha are starting up a Chemsex support group as well, and that's for people who are abstinent, because that and that's their ethos, and that's to them, right? But that's another support, and it's great that these supports now are happening, and especially peer support, because an individual knows, right, they know my story, because I can relate to that, and they can relate to me, and that is so important,
especially if you're isolated. You might not want to go to a social group initially, but even having that one person might help. And Ralph, if I can bring you back in, because we talked about the sociality of chems initially, right, and then leading to the isolation. And we're talking about Kinder, which is based in Dublin. We talked about, the previous survey that was based in Dublin. But of course, Chemsex isn't localized to Dublin. Of course, it's, the capital city. We're going to see lots of it. But what do you know from your public health experience, from the data, or even anecdotal, I don't know, like what's happening outside of Dublin?
It's great crack, Robbie.
Cultures can handle their chems better than Dublin people. There's no problems outside of Dublin at all.
But it's really actually such an important question, and something we really wanted to answer, I think, because there is no real data there. And I think what's also quite shocking is how limited the services are now in Ireland generally, but particularly in rural areas. So part of the work in putting together the survey was kind of scoping out what services do exist if you do want support with your chems use. And unfortunately, outside of Dublin, there honestly isn't any specific service for people experiencing chems use. Now there are the Sexual Health Centre in Cork. They've kind of said they would be keen to take, and Limerick as well, to help people, which is fantastic. But kind of after that, for example, it's really just kind of the luck of the draw, you could say, based on what mental health supports you might be able to, or addiction supports you might be able to get locally, which can vary hugely. And I think that is so problematic. And the services in Dublin are seeing people from, like, you know, the top of Donegal, and that's just not fair for people living in rural Ireland. I'm from rural Ireland, and it isn't just, I suppose, that, you know, if you're from a rural county, that it's just so much harder to receive support. And when you think of the barriers it takes for somebody to access support, if you have to, like, take a day off work to travel up to Dublin, like, that's a massive barrier for so many people. And it's really important to talk about that. And I think even, like, where people live can affect, for example, like the mental health care supports they can get within the public system. One thing we kind of wanted to figure out in the survey is also where people are using Chems, like, because if you're somebody, say, that is from Tipperary, but you're coming up for a Chems party at the weekend in Dublin, your access to public mental health supports will still be based on your address in Tipperary. So it's important that we actually know, like, where people are living so that they can get the supports they need.
And how do we do that? Like, I often feel like people, it applies to people living with HIV, I think, as well. Often it has to be peer support, and it has to be peer-to-peer support, because the services don't extend far enough for them to have actual services, you know?
I think the community as a whole needs to speak up as well.
Yeah.
Because, again, that silence, and I've highlighted this at the Gay Men's Health Conference, and when I speak at LGBTI service and stuff, I always go, guys, these conversations not happen, right? Not only, like, I touched upon two really dark areas, but another one is, right, or I mentioned deaths, I mentioned the isolation thing, I mentioned IPV, intimate partner violence, rape, again, the silence. The amount of individuals I'm working with who've experienced serious sexual assault and rape on this scene.
Yeah.
Right? Because, again, that's tapping into that vulnerability and exploitation.
And again, we're getting into something that people struggle so hard to talk about.
The double closet again.
Conversation is, again, it's so important. When you said that, and this is not my ego, it's just, I think, the truth, that at Pride, the last couple of years, the only people holding up signs that are about chemsex and looking for chemsex services are us. And we're a very big community. I mean, the queer community, not us. And you would think other people would care.
Like,
but
it's almost like listening to
it's hot like potato situation.
It's like the two of you and, like, the stuff you're doing. I'm just absolutely delighted to see you on the HIV campaign, right? And listening to yourself that morning driving up stuck in traffic. You're on, I think, Morning Ireland or something, right? But it's almost like you're the act up in relation to chemsex. You're the only ones that are highlighting this.
And we struggle to do it too. To be honest,
it's heavy. It's heavy. There's no denying it's heavy, but it's important. We can't let people die in our community for no reason. And we know statistically that people living with HIV are more likely to engage in chemsex. It's very much a health issue within our health issue, you know, and it's for many reasons that we talked about, you know, issues around intimacy, community, connection, not having, people don't care if you're undetectable or on PrEP, you know what I mean? It's all of these different things. And it's chicken egg. Do you get HIV from being a chemsex parties, or do you get it before blah, blah, blah? We don't have the data even to back that up so much. But it's something that is very much within our community, and we're not going to hide it in the corner because it's might stigmatize us more. It's something that we actually say, actually, no, this is a health issue within our community. Let's shine a light on it in a non-judgmental way, and say, come talk to us about it. That's what we're here for. You shouldn't have shame. And if you think it's getting to problematic use, please go see someone, and these are the pathways. And we're going to fight for extra pathways for you.
And can we say also, if you've experienced rape, please come and talk to someone, get some help, talk to friends. Don't try to go through that on your own. I think it will drive you further into addiction. Most rapes are not reported. Most rapes are not prosecuted. But to be honest, most rapes are not even spoken of.
Yes. And, you know, you use the term there, further into addiction. To me, further into self-medicating.
Sorry.
And, you know, sorry for being so pedantic.
No, you're right.
But even, and listen, come here, you know, the Dublin Rare Crisis Centre, absolutely phenomenal service, offering incredible support for people, right?
Is self-medication self-love, though, Graham?
Oh, absolutely, yeah. But, you know, certain services are not open to people if they are perceived as being in active addiction.
Wow.
that a person, yes.
Okay.
If someone you talked about mental health, if someone wants to access community mental health services, again, from my experience of various community mental health areas, a person has to be at least 6 months drug-free, chem-free, substance-free, sober, before a referral can be sent.
You have to lie, don't you?
Yes.
I mean, who doesn't? You know what I mean?
We tell people, you're not a good candidate for PrEP, lie to hell to that doctor. If you want DoxyPep, lie to hell to that doctor.
But again, the same with regard to therapy.
Lie to hell, they don't know.
People
They don't
ask
care.
me that, I say lie.
Yeah.
Not,
But even at that, and
to
this is
undermine
where
the therapy, but just to get therapy.
And like it's not so much that even, if someone has done the 6 months chem-free and all of that, this is where the cultural competency comes into it. And they may engage with a psychiatrist or a reg or whatever. If that person is not tooled up in issues around the community, around sexuality, around chemsex, that person, the individual sitting before them is not going to open up. Because if they say, oh, I've been smoking Tina, what's that?
You're gone.
Yep.
You lost them.
I kind of interrupted a minute ago, Graham, with a question, and then it kind of went by the wayside, but it interests me, so I want to bring it up again. Because I struggle with self-love and self-care. I think older gay men is quite a common thing, and I think also living with HIV and the challenges, as well as surviving abuse, so many things that all are themes that we're talking about when it comes to chemsex. So I'm going to ask again about self-medication. Is self-medication self-care?
I think it'd be that's a really interesting question, because you could because what I'm seeing in my head is, on one hand, self-harm, self-injury, and on the other extreme then, self-care, self-love, right? And I think for what comes to mind first off, and this is actually a model I'm going to use now with people, and almost do that, 1 to 10 on both sides. Where do you see yourself and your use at the moment? So thank you for that. And I genuinely will do that. I think it's a really excellent point, that I think at various times where someone might be, it could be that self-care, self-love, right? But on other instances then, it could be that self-injury, self-harm. And one person comes to mind, and there's quite a few actually, right? And when life is going good for this guy, he will engage with some friends that he would party with every so often, TG, cocaine, and it would be a very pleasurable experience. And there would be very little of a come down or a psychological fallout or consequences, right? But if his life is not going well for a period, he will engage with others and they will humiliate him. And they will bring him to a place where he believes, this is where I belong, Graham. This is who I really am.
The George. Just kidding.
Jesus, no.
Shirley Temple Bar, your client.
I'm sorry, that's my self-preservation. I kind of go to humour. When my triggers are when Annie Oakley is...
But, so on one area it would be absolute self-care, self-love, right? But on, if things aren't going well for him, and that guilt, shame, blame really kicks in, and this is my fault, there's something wrong with me, right? That it's the same chems, right? The same hotel, but a very different mindset. Context. And he will consensually put out to be absolutely humiliated, and the kind of psychological fallout from that will go on then for a number of weeks afterwards for him.
It's very complex, isn't it? I was talking to a couple of alcoholics said this to me, and I found it fascinating that actually the alcoholism saved their lives because they couldn't cope with coming to terms with the sex abuse they had as kids, like losing their families, and actually it was that escape, momentary as it was, but allowed them to live for a few years when they thought they were going to top themselves, and then they eventually were able to find help because they had the rock bottom. And it's not to say, and I think it was that kind of, it was the only medicine that they thought that they could cling in at the time, cling on to, until they eventually were able to find a way out of the vicious cycle of any ism. And so
or not,
or not.
that's
the other side
function.
of it.
Yeah, sorry.
No, it's true. That's why it's
Yeah.
so complex, isn't
Yeah.
it? I'm just hearing from the people on the other side.
Yeah.
When there's
There's lots
people
of
still
people,
going
there is
through.
no other side.
Exactly.
And it's just,
Yeah.
I just do this, and
Yeah.
this is how I self-medicate and how I
Yeah.
get by.
Exactly.
Like as David Stewart said on the ChemSex documentary from 2016 now, I think it was, you know, people just think it's gay boys going out taking drugs and having sex.
Mhm.
It's far more complex than that.
Uh-huh.
Due to the complexity, we need data to help, you know, unpack this complexity. What do we want from CHEMSI? Like, how many people do we want to gain access to this? What can people in the community do to make sure that so many people, because do this survey? We know how important it is. We want to get as many voices represented throughout Ireland. So what can people do to sign up to do the survey?
The ChemSi survey.
The ChemSi survey, exactly.
So we'd really love like as many people as possible to answer the survey. So basically we're looking for gay, bisexual and other men who have sex with men, trans people and non-binary people living in Ireland. Like that is the population, and we want as many people as possible to
The
fill in
Republic
the
of
survey.
Ireland or Northern Ireland as well?
Republic of Ireland.
Okay.
We would have loved to have Northern Ireland included, but we couldn't for kind of practical reasons. So you don't have to use chems to take part. That's actually really key to mention. We are particularly interested in hearing from those who use chems, but it's also really important for us to hear from people who aren't using chems within the community, because being honest, it affects everybody within the community. Like, you know, and those who are engaging in like chems spaces, like attending like chems parties that maybe mightn't be using chems themselves, or even if you're not in that bracket, because it's useful to be able to kind of compare and contrast to see like what people are using and the effects that it's having. But the aim ultimately is to build better services. So the more people that fill in the survey, the more experiences we hear, the more diverse the people filling in the survey, ultimately we can say, well, this is what people want. So we can say, you know, like I am now in the HSC, but we can say, okay, we can get funding and say, well, this is like people want, for example, like a one-stop shop model, or people want care in, you know, in a particular way online, you know, peer support, and then say, well, this is what people want. This is what we need. And there are kind of models abroad that I think we can, you know, learn from. Like I've spent time in France before, and they have like these kind of really nice kind of one-stop kind of shop approaches. So like in Paris, there's a really great center called Checkpoint, and you can basically get like all of your sexual health care there. You can get like trans-related care there. You can get, and they have like kind of like addiction support, mental health support. You can get, you know, syringes, like equipment if that's what you need, and kind of everything is there. And I think there is an interest, like say, in the Gay Men's Health Service, like David Fields and the team there, they're doing
Shout out
incredible
to
work,
them.
and they want to be able to do more, but it's just we don't have the resources yet to have like more David Fields or more Grahams in this world. But that's really what we want, is to have, again, like community built centres, you know, where people feel at home, because within the healthcare service, and I'm saying that from somebody who's worked in it, again, as Graham was saying, like there still unfortunately is like too much prejudice in the healthcare service at large, so that we want places that are culturally competent.
That's a great clarion call, and we're gonna loud and clear, and it's something that we all have to fight for. But I'm gonna ask you one more question, Ralph, before you give the last word to Graham, because I think we're coming up to time. You are a polyglot, is that true, Ralph? How many languages can you speak?
I suppose it's kind of like a hobby, really.
No, come on, don't be humble.
like a decent handful, I'll say. But
come on, how many?
Like you could say like between 6 and 9, depending on what
I can barely
definition.
speak English.
He's reading all of the surveys in every language.
Exactly. The reason why I asked this is because you put a new word on Gaeilge, right? Do you want to just say what the word is?
So it's actually a really fun thing to do. So the word for chemsex in Irish that I suppose I came up with was chemgenees. So it kind of literally translates as chemsex. So when we were getting the survey translated, and we wanted the survey to be as successful as possible, we got it kind of officially translated into Irish, but it was translated as kind of like Gneis Hui Hunker Chemicon, which is like sex under the influence of chemicals, and it's just not a very like you know, sexy combination of words to put in a poster. So we said we should just make a new word, and there's actually an official way of kind of like applying to have a word registered. So kind of went about that process, and it's now in the dictionary, which is exciting.
Wow.
It's important to mention actually that David Stewart initially came up with the word chemsex, and I was blessed to have met him back in 2017, I think.
Well, now you came up with Chem Guinness, so all those who having sex in Connemara, you can now Come to my Chem Guinness party.
That would be a brilliant name for us if and when we do, 'cause it is needed.
Oh, of course.
That standalone services. That would be an excellent name for it.
That could be good fun, actually. Yeah. Graham, I want to give you the last word, okay?
Sure.
And I've been doing this with all my research participants. I want to give you a magic wand, right? Because you're at the forefront of this battle to be heard about chemsex or Chem Guinness or Guinness. So I want to give you a magic wand. Department of Health is listening to you over there, and they're going to give you all the resources you need with the HSE. And I know they do think this as an issue now and that they want to address it. So this is fantastic. Based upon all your experience, everything you've heard, what do you think the Irish government can practically do? The community have to be involved and we can do our practical things. But what can the government actually do that you see that we need?
Very simple. Number one, a much broader conversation, because it's not happening.
Yeah.
Right, and that's right across the board. But services across the country based on the English model of the Club Drug Clinic, that one-stop shop that Ralph mentioned earlier on. We don't have to reinvent the wheel here.
Yeah.
Right? Heroin wasn't properly addressed until the mid-90s with the National Drug Strategy and the Drugs Task Forces, right? In the intervening years from the late 70s until the mid-90s, a lot of people died through heroin, through HIV, through hepatitis. And this is happening again. Okay, there are waiting lists that are too long for G-detox, and that's not right. Like I said, we don't have to reinvent the wheel here. We have a model across the UK, across Europe. We can learn, like Ralph mentioned, Australia earlier on. This isn't just a phenomenon in Dublin, right? We have something that we can work off, right? And that's what we need to do. You know, it does take money, but listen, prep, how much, it can be done, but we need that. I just hope it doesn't take some absolute crisis or a celebrity or something dying to put this, to give it the gravitas it requires. The state responded to cocaine within 18 months.
Yep.
Because it wasn't confined, and this is my own personal thing, right? And a community perspective. It wasn't just confined to working class areas, right? That cocaine was across all structure of society, and it was responded to much, much quicker.
Yeah, well said.
The kind of moral panic that was created in relation to the head shops, that was responded to within 12 months.
Yeah.
And we had legislation introduced that got them shut down. I'm working on this on a daily basis since March 2015.
Because we're the ghetto.
Yeah. So
and we're gay and bi people.
And this needs, and just one last point, because I collect me own data every year, and like 2025 was the first year that international engagement was greater than Irish engagement. That for new people, there was 27 international engagements last year of new people. And 24 Irish. Overall, in 2025, I worked with 212 separate individuals. Be that one-to-one therapeutic and support counselling work, be it harm reduction, crisis intervention, relapse relapse prevention and stuff, but also advocating and agitating for people. Right.
And that's a health equity issue then, isn't it?
Yes.
Because we need to make sure that everyone who is in Ireland gets the health that they deserve. So there can be language barriers. I know that's something you're very passionate about, Ralph, or people just don't know the services that are out there for them, so they go through it alone because they don't know what's there.
Like my fear is that if we have an increase in HIV numbers or STI numbers, that will be responded to on a public health issue, right? This is not just about people using drugs. It's not just about addiction. It's, again, far more complex than this, and we need to respond to it in that broad consensus.
Okay. I don't know about all of the listeners at home, but I found this hugely informative. I could listen to you all day long, to both of you. I'm so happy that you're doing this survey, that we're collecting the data, and I'm so happy that you're advocating and agitating, and we're all in this together. For anyone who wants to, who feels that they need extra help after hearing this, they identify, actually, maybe I am going to more problematic chems use, how do they get in contact with you, Graham, or how can we refer them? Where's
Number
the best
one, I would be anyone that's listening to this that in any way needs, at whatever level they are at, right, or even just a conversation, please contact me, 085 133 7536, or graham@rcdt.ie. I'd be happy to take that call.
Graham, you are a straight man, but I think you should be the Grand Marshal of Next Dublin Pride, can we just say? And for everyone who wants to do the survey, it's mantoman.ie/ChemSex survey. Everyone needs to do it. The more voices, the more power and statistical power we have, and we can fight for more resources and funding.
Yeah, please take the survey. It's really important that we get to hear from you and that the services are tailor-made to be the services that we really need.
Okay, everyone, thank you for listening to this podcast. It's hugely important. It's important for whether chemsex is part of your life or not. I think it's very human, and shows you all the obstacles and hurdles that we still need to jump through.
Hoops.
Okay, everyone, remember to stay positive
and stay medicated.
Self-medicated. Bye.
Thank you so much for listening to Pause Vibe Podcast. If you enjoyed this week's episode, show us you care by leaving a review wherever you listen. And don't forget to follow us on social media at Pause Vibe Podcast for all the latest news and updates.